Welcome everyone to a new episode of Nerve Talk. Today we have with us powerhouse in peripheral nerve surgery, Dr. Fausto Viterbo. Welcome, doctor. As you know, Dr. Viterbo is from Brazil. He coursed medical school at the Universidad Federal do Rio Grande do Sul in Porto Alegre, and did plastic surgery residency at Hospital da Beneficência Portuguesa in Sao Paulo, and he graduated in 1981. He did a master's degree and graduated with a thesis denervation, contributions to the histoenzymatologic study of the gracilis muscle of the dog, and then did a doctorate thesis on endocyte neuropathy experimental study on rats, which is probably one of his most famous works to this date. He then did postdoctorate studies at the University of Pittsburgh and developed experimental studies on enzymatic activity on endocyte neuropathy and neuroma prevention. He's currently a professor of plastic surgery at Botucatu School of Medicine. He also runs a successful private practice at Clínica de Cirugía Plástica Fausto Viterbo, where he performs reconstructive surgery, cosmetic surgery for the body and the facial structures. And he has developed all sorts of peripheral nerve reconstructive procedures, going from facial paralysis to penile renervation, olfactory renervation. So it's amazing to have you here and also have a fellow Latin American colleague with us. Welcome, doctor.
Thank you so much. It's a great honor to be here.
So we wanted to start asking you, how did you become interested in peripheral nerve surgery first? Was the 80s, there wasn't much literature to go around. So what got you in this area?
When I was a student, when I was in the 5th year student, and after in the residency of general surgery, I was very impacted with paraplegic patients, because the most paraplegic patients I've seen in that time was young patients that had car accident or motorcycle accident at the same age of I was in that time. And that touched me very deeply, because their lives was completely compromised, you know, for the rest of their lives. And so since that, then I start thinking about what to do in these patients. And then I came to Sao Paulo to do a residency in plastic surgery with the famous George Psilax. It was a very, very famous plastic surgeon who introduced the craniofacial surgery in South America. And we did a lot of big surgeries in craniofacial, like hypertelorism, Eppler-Cruzon syndromes, and everything. And in that time, I was very interested in come back to Porto Alegre, to my city, and to be professor and especially researcher. I almost love to do research. I almost have ideas, you know. When I was president in general surgery, when I saw some surgery, I thought, but it's impossible. It must have a new option, another option. This could be easier. This could be better, you know. I was always thinking how to do better, some technique. And then I was finishing my residency in plastic surgery. I went to Porto Alegre to talk with the employees to know what I had to do to become a professor. And they told me that in that time they will open exams, selections, and it would be very nice if I could have a master course. A master degree could help me a lot, because no one in that time has. This I'm talking about 1979, 1980, more or less. And then I discovered that in Sao Paulo, there was no space to do. They doesn't have a space to do post-graduation. But there was a small city in the countryside called Botucatu that I've never heard about the city. This very strange name is an Indian name that has a good course of surgery, post-graduation in surgery, especially experimental surgery, research in surgery. Then I came to Botucatu to visit the university. I was impressed. It was a huge university with a terrific lab with rats, cats, rabbits, dogs, pigs, any animal to do research. A lot of technicians, material, microscopes. I say, oh my gosh, I will spend 2 years here. I will do my master and I will come back to Porto Alegre and be professor and researcher. And then, but the city was very, very small. You know, I say 2 years, it will be enough. But then I decide to do the doctorate after master, to be stronger in the exam selection in Porto Alegre. And then in the master, I had an idea. No, then I have to select advisor, a professor advisor, a orientador. And this professor asked me, do you have an idea to do your research? And I say, I don't have an idea. I have a dream. My dream is to make a paraplegic walk. He say, oh, it's very, very, very pretentious. This is almost impossible. I say, yes, I have this dream. They say, okay, do you have an idea how to do that? I say, I have an idea. What do you intend to do? I have the idea to connect nerve grafts in the peripheral nerves above the spine lesion and connect like bridges to nerves below in the lower limbs. You say, oh, this is a good idea. So to start in the master, you will study a muscle denervation, and in the doctorate, you will study a reinnervation, and then you will try to do your idea to paraplegic in animals, probably pigs. I say, perfect. And so in the master, the idea is to cut the operator nerve and to denervate the gracilis muscle in dogs. So I went there, I dissect the branch of the operator nerve, I cut it, I invert the stumps and suture with a 4-0 nylon, 4 zeros nylon, apart with 3 stitches. The first dog, the muscle was atrophied, so we did histology, morphometry, a lot of things. But one of the dogs, the endings of the nerve was disconnected and they reach each other again and they reinnervate. The muscle was perfect. In the first moment, I say, oh, it's a pity because I have to do other surgery on another dog. But then I thought, how strong is the nature stimulus to connect nerves? Because I put 2 stitches, 4-0 is a big suture for a small nerve, you know, and the nature connect them. And then I had the idea in this day, what could happen if I suture a cut nerve in a normal nerve? The answer is nothing. Nothing is impossible. Then I read a lot of papers and so, and the answer was no way, it's impossible. It has three connective tissue layers, epineuro, perineural, endoneural, that protects the axons about any lack of blood or electrical stimulus. And this doesn't allow the axons to grow through this. But as I told you, the lab here is spectacular. Is this the reason that I live here until now? I do surgery on rats every Tuesday morning. I go there with new ideas, new ideas, and a lot of students working and residents researching. And so I did this in my doctorate, end-to-side with dogs. And then it was amazing because when I opened the dogs, the muscle was perfect. I went a very good reinnervation, you know. And then I start fighting against the world because it was something totally new. No one believes about that. No one. And then I defended that. I presented this thesis in 92. A very famous doctor in Brazil almost beat me. He said in this day, this is impossible. This is not in the Sunderland Treaty, Tratado de Sunderland. This is not there. The man that, no, I say, I'm very happy that it's not there. It's a new thing. We are working with new things. If it was in the Tratado,
Welcome everyone to a new episode of. So how have you combined doing this reconstructive work with peripheral nerve surgery and incorporating it in your aesthetic surgery practice?
Because I had a good formation. This professor George Psilax was a very good man in craniofacial and aesthetic surgery, you know. So I love aesthetic surgery. I had a lot of I am very happy when I do a aesthetic surgery and I change the life of the patient, you know, in a nose, in a facelifting, in some orthogenetic surgeries, and many aspects of the surgery. This gave me a lot of satisfaction to see that I improve the lives of the patient. And the same satisfaction I have when I change the life of a patient with facial palsy or other nerve disorder. And in facial palsy specifically, I think aesthetic and reconstructive are very connected. They are joint, are the same thing. Many patients has a facial palsy, an incomplete facial palsy, that they can close their eyes, they can eat without lost any liquid, but it's a pure cosmetic complaint, you know. I'm very ugly with this asymmetry. Asymmetry makes us very ugly. And so I use cosmetic surgery in facial palsy. It's very common when an old patient has problems with facial palsy. I do a facelift, a complete facelift.
For our next question, you already told us a bit about your story as for how you started your research, your thesis, your publications. But once you were done with residency, the doctorate, how did you first start your peripheral nerve research lab and your projects, and how did you get everything started, especially at a time where there was really very little research and maybe uh, very little interest even in developing this area?
Yeah, yeah. I have I'm very lucky to have been in Botucatu to and to see this lab. This university is a huge university, very good university, and we have a experimental lab that you can imagine is a building. Is a building with a lot of rooms, a lot of employees, you know, and many guys researching in many areas. And so it's very easy to do research in Botucatu. This is I have fellows from all over the world, and especially people from Egypt. I had two guys from Egypt that was doing his thesis in Egypt, but it was very hard to do the idea and to do. So they spent 1 year with me operating 100 of rats and did all the studies, electromyography, histology, nerve histology with everything, and did a huge, very good work. And so, and many other guys came, I put them to research also. I think it's very important the surgeon to be researcher, you know, this make a huge difference. I, I am working, doing a cosmetic surgery. I know what I'm removing the orbicular muscle, but how much I can remove this muscle, what the percentage I can remove without impair the too close. Then go to the rabbits, remove muscles and see. So the questions you can answer in the lab, you know, easily with no bureaucracy, small bureaucracy. And so I think this is fundamental. And this is the reason why I am staying in Botucatu.
So I think I know the answer to this first one. So for nerve repair, end to end or end to side?
It depends. It depends. If you have a nerve that was cut and you have both endings, for sure you should do an end to end. But if you want to neurotize a muscle with a nerve graft, I don't cut nerves. I put them to side and connect her. And I publish a paper doing in rats a research comparing end to end to side, but not like other papers that did that say that end to end is superior because they use different donors. You know, if you use a different donor, you may have different answers. But using the same donor, you can reach it in by PubMed, or if you want, I can send this paper to you. And it was amazing. It was the same result, you know. But so I don't will cut a nerve if I can have the same result doing end to side.
Wow, thank you.
Not sacrificing donor nerves. No, I think this is the great thing in end to side. This open up because any nerve may be used as donor. So this open up many options. No, great potential.
Amazing. So for facial paralysis, temporalis muscle transfer or gracilis muscle transfer?
Temporalis for sure. Why? Because temporalis no bulky, no asymmetry. In terms of symmetry, temporalis is better. Gracilis in good hands like Ron Zucker, Greg Borchell, Manfred Frey. You know, you have Julia Terzis, and there are colleagues that use the gracilis in a way that the symmetry is very acceptable. But the great majority, we have Alexandre Cardenas that has good results also, that is Mexican. But the great majority of cases that I've seen, it's very asymmetrical because it's bulky, because it's very difficult. You choose the amount of muscle you need. If you put more muscle, you get asymmetry. If you put less muscle than the ideal, you don't have power to move, you know. So it's not for anyone to have good results with gracilis. So gracilis for me is in cases where the temporalis didn't work. And the port, the the gracilis is a big surgery. You know, sometimes it's 6 hours, 10 hours doing. Is anastomosis. In anastomosis, you have thrombosis risk. So there is a lot of things. Agora, the temporalis, no, you don't need microscope, you don't need anything. It's a very simple surgery with good results. I have a couple of patients that did gracilis and came to me to remove the gracilis and put the temporalis, you know. So for me, first choice, temporalis. When doesn't work, gracilis.
Great, thank you. As for your nerve repairs, what do you prefer using, sutures or fibrin glue?
Sutures. I trust more in sutures.
Amazing. And do you prefer using loops or a surgical microscope?
Loops, as when loops is enough, loops.
Thank you for your time. With this, we conclude this episode of Nerve Talk. Thank you to everyone for connecting, for watching us today. And if you have any questions, you wish to contact Dr. Viterbo, ask about the fellowship opportunity, we'll be adding all the information in this post description. Thank you for your time, Dr. Viterbo, and it was amazing. I'm looking forward to meeting you, maybe the Mexican meeting or WSRM later.
Yeah, exactly. Thank you. Very nice to meet you here. And thank you for the opportunity. A great honor for me.